Welcome to the Deep Dive. This is where you send us what you need to get your head around, and we pull out the really key stuff.
Mm-hmm.
Today, we're looking at some revision notes sent in by the learner all about genital herpes. Our aim is to make this stick, using some memory tricks and keeping it clear.
Exactly. And these notes are pretty thorough, covering everything from the basic definition right through to complications. It's obviously a sensitive topic, so we'll be aiming for a really helpful fact-based discussion, easy to recall.
Okay, brilliant. Let's dive straight in then. The definition. What exactly is genital herpes?
Okay, so put simply, it's a sexually transmitted infection, an STI. It's caused by the herpes simplex virus, or HSV, and the main thing people notice, recurrent, often painful sores or blisters, usually on or around the genitals.
Right. And the notes mention two types, HSV1 and HSV2. What's the key thing we need to grasp there?
Yeah, that's a really important point. Traditionally, we thought HSV1 equals cold sores, HSV2 equals genital, but it's much more overlapped now.
Overlapped, how so?
Well, HSV1, the typical cold sore virus, can definitely cause genital herpes, often through oral sex. And conversely, HSV2 can sometimes cause infections around the mouth.
Ah, okay. So it's less about location and more about either virus causing issues in either place.
Precisely. Either virus can infect either mucosal surface, essentially.
Got it. Okay, so moving to etiology then, the causes. What's the main driver?
The primary cause is still HSV2, but, and this is crucial, HSV1 is a really significant secondary cause now, especially in younger people in places like the UK.
In transmission, how does it actually spread?
It's all about direct contact with infected skin or mucous membranes, so usually through sexual activity, vaginal, anal, or oral sex.
Direct contact.
Okay.
And you mentioned oral sex, so it's not just genital to genital.
No, absolutely not. Both HSV1 and HSV2 can infect the mouth and the genitals. You can also get autoinoculation. Like, if someone touches an active sore and then touches another part of their body, say their eye, they could potentially spread it there. The virus is present in those secretions from the lesions. Even contact with a lesion on someone's finger, like herpetic whitlow, could transmit it.
Okay, this seems huge. The notes really stress asymptomatic shedding. Why is that so important?
It's absolutely key because a huge amount of transmission, maybe around 80%, happens when the person doesn't have any symptoms. They're shedding the virus from their skin or mucous membranes without any visible sores, often without even knowing it.
Wow, 80%. That explains a lot.
It does. And linking back to HSV1, the notes highlight it's now a very common cause of genital herpes in the UK, often from oral sex transmission from someone with cold sores. HSV2 is still mainly anogenital, but overall, HSV1 causes more infections, both oral and genital.
And that asymptomatic shedding, the notes mention it can cause real distress in long-term relationships, right?
Right.
Because someone might transmit it without knowing they even had it for years.
Exactly. It can be very difficult emotionally. People assume infidelity sometimes when actually the virus could have been latent for a very long time.
Okay, so we understand the cause and how it spreads.
Mm-hmm.
Who's particularly at risk? What are the risk factors to keep in mind?
Well, the notes list several pretty clear ones, things like unprotected sexual intercourse, obviously. Having multiple sexual partners increases exposure risk.
Makes sense.
A history of other STIs also seems to play a role, maybe indicating higher risk behaviors or perhaps some biological vulnerability. And starting sexual activity at a younger age is also listed.
Okay. Anything else?
Yes, a few more points. Men who have sex with men are noted as a higher risk group. Also, anyone with a weakened immune system. Interestingly, female gender carries a higher risk anatomically, and people living with HIV are also more susceptible.
Right, so a mix of behavioral and biological factors. Okay, so let's get into the pathophysiology. What's actually happening biologically when someone gets infected?
Okay, so picture the virus entering the body, usually through tiny, maybe even invisible, breaks in the skin or mucous membranes. That's the initial infection. But the clever thing, or the problematic thing about HSV, is that it doesn't just get cleared by the immune system.
It hides.
Essentially, yes. It travels up the sensory nerves from the site of infection and sets up shop in the nerve cell bodies, the ganglia. It establishes a latent infection there. It basically goes dormant.
Right, like it's sleeping in the nerve cells.
Exactly. And then later on, could be weeks, months, or even years, something can trigger it to reactivate. We don't always know the trigger. Could be stress, illness, sunlight, menstruation.
And reactivation means?
The virus starts replicating again within that nerve cell, travels back down the nerve fiber to the skin or mucous membrane surface near the original infection site, and that causes the characteristic outbreak, the sores, the blisters.
Ah, okay, so the recurrences are the virus waking up and traveling back. Got it. Now, if someone presents with those kinds of symptoms, what else might be going on? The differential diagnosis section seems really important.
It's critical. You don't want to miss herpes, but you also don't want to misdiagnose something else as herpes. There are quite a few conditions that can mimic it.
Like what?
Okay, let's try that mnemonic from the notes. Very often, similar skin stuff requires better guessing how. Does that help?
Let's see. Vulvovaginal candidiasis. Thrush?
Yep. Oh, for other STIs, think gonorrhea, maybe bacterial vaginosis, and definitely syphilis. Though remember, syphilis ulcers are typically painless. That's a key differentiator.
Painless syphilis ulcers, okay. Skin stuff.
Exactly. Similar skin stuff like scabies, psoriasis, contact or atopic dermatitis, folliculitis, maybe lichen sclerosis.
Right.
R for reactive arthritis. S for systemic conditions like Behçet syndrome. B, maybe other bacterial infections. G, genital malignancy, though rare. H, herpes zoster, shingles, you got it. Herpes zoster is important, but remember, zoster is usually unilateral. It follows one nerve dermatome, so it doesn't typically cross the midline. Genital herpes can be unilateral, especially in recurrences, but primary infections are often bilateral.
Okay, that's a helpful distinction. And the mnemonic is good. Very often similar skin stuff requires better guessing how. Great for recall.
Okay.
So how common actually is genital herpes? What's the epidemiology look like?
It's very common. The notes state it clearly a common STI in the UK. Lots of new diagnoses every year. Predictably, it's more prevalent among sexually active people, particularly those engaging in unprotected sex or with multiple partners.
Are there any specific numbers?
Yeah. The notes cite data from England in 2015, over 30,000 cases diagnosed just in sexual health clinics, and a significant chunk, 41%, were in the 15 to 24 age group.
Wow, nearly half in that younger group.
And while most diagnoses, about 92%, were in heterosexual men and women, about 12% of the male diagnoses were in men who have sex with men, so it affects all groups.
Really puts it into perspective. Okay, so let's talk clinical features. What are the actual signs and symptoms someone might experience?
The absolute classic is painful sores or blisters. These can be on the genitals, the buttocks, thighs, around the rectum, sometimes even the mouth, depending on the transmission route.
Painful sores. What else?
Often there's itching or tingling, sometimes called a prodrome, before the sores actually appear. Flu-like symptoms can also happen, especially with a first episode fever, muscle aches, just feeling generally unwell. Swollen lymph nodes in the groin are also common.
So painful genital ulceration is key, maybe with dysuria, pain, passing urine, and pruritus itching.
Exactly. Those are very common features.
And the notes draw a distinction between the primary infection and recurrent ones.
Yeah.
How do they differ?
Yeah, that's important. The primary infection, the very first time someone gets it, is often, though not always, the most severe. You're more likely to get those systemic symptoms, headache, fever, malaise. The lymph nodes in the groin might be quite tender. It can even cause urinary retention in some cases, difficulty peeing.
And it lasts longer.
It can do, yeah, up to 4 weeks if it's not treated. And it might be asymptomatic too, which complicates things. Recurrent infections, on the other hand, are usually shorter, maybe a week or so. Symptoms tend to be milder, more localized, often just the sores without the flu-like feeling. And the lesions often appear unilaterally, just on one side.
Do recurrences happen often?
It really varies. HSV2 tends to recur more frequently than HSV1 in the genital area. But the crucial thing, again, is that transmission can happen even between outbreaks or years after the initial infection, even if recurrences become infrequent.
Okay. So, someone suspects they have it, they go to the doctor. How is it actually diagnosed? What investigations are done?
Well, often a clinician can make a presumptive diagnosis based on the appearance of the sores during a physical exam. But laboratory testing is really the gold standard for confirmation.
What kind of tests?
The preferred method now is nucleic acid amplification tests, NADEX. That's usually done on a swab taken directly from the base of a sore or blister.
Why not?
They're highly sensitive and specific for detecting the virus's genetic material, the DNA. They're generally better than the older method of viral culture, which tried to actually grow the virus from the swab sample. Culture is less sensitive, especially for healing lesions.
Okay, NANs from a swab. What about blood tests? Serology.
Serology, which looks for antibodies to HSV in the blood, has a specific role. It's not usually the first-line test for diagnosing an active outbreak, but it can be useful in certain situations.
Such as?
Like if someone has recurrent genital symptoms, maybe atypical ulcers, but the swabs keep coming back negative. Or for partner notification, finding out if a partner has been exposed. It can distinguish between HSV1 and HSV2, which can be helpful for counseling about prognosis, as HSV2 tends to recur more genitally.
Right.
Also potentially useful in pregnancy management or as part of screening for someone at high risk of STIs, but there's a catch.
Which is?
It can take time for antibodies to develop, up to 12 weeks, sometimes longer after the initial infection. So a negative blood test early on doesn't completely rule out a recent infection.
Okay, that's important context. So NATRs are key for active lesions. Serology has specific uses later on, right? Diagnosis confirmed. What's the management strategy?
The main goals are threefold. Relieve the symptoms of an outbreak, reduce the frequency and severity of future outbreaks, and crucially, prevent transmission to partners.
How do you achieve that? Medications.
Yes, antiviral medications are the cornerstone. Acyclovir, valacyclovir, famciclovir. They work by stopping the virus from replicating. They don't cure it, the virus stays latent in the nerves, but they can shorten the duration of an outbreak, reduce the severity, and make it less painful.
So you take them when you have an outbreak?
You can, yes. That's called episodic therapy. You start taking the tablets as soon as you feel an outbreak coming on or when the first sores appear. The other approach for people who have frequent or very severe recurrences is suppressive therapy.
Taking them all the time?
Taking a lower dose of the antiviral every day, long term. This can significantly reduce how often outbreaks happen, sometimes stopping them altogether. And it also reduces asymptomatic shedding, which lowers the transmission risk.
Okay. And what about just managing the symptoms when they occur?
Good point. Supportive measures are really important too. Things like keeping the area clean and dry. Saline bathing, just sitting in a shallow bath of warm salt water, can be soothing and help keep lesions clean. Simple analgesia like paracetamol or ibuprofen for pain. Topical anesthetics like lidocaine gel can help numb the area, especially before urinating if that's painful. And the notes mention Vaseline as a barrier cream during urination too.
Right, practical tips. Is the management different for that first primary episode?
Generally, yes. For a primary infection, referral to a GUM clinic, genitourinary medicine, is usually recommended. They can confirm the diagnosis, provide treatment, and offer really important counseling and support. Antiviral therapy is strongly advised for primary episodes, ideally started within 5 days of symptoms appearing, to reduce severity and duration.
And for recurrent infections?
That's where the choice between episodic and suppressive therapy comes in, based on the individual's needs and preferences. If someone's on suppressive therapy, it's usually reassessed after about 12 months to see if it's still needed.
You mentioned counseling being important. Can you elaborate on that?
Absolutely vital. Getting a diagnosis of herpes can be emotionally challenging for many people. There's still, unfortunately, a lot of stigma attached. So counseling needs to cover the nature of the condition, that it's manageable, common, doesn't cause long-term physical harm in most people.
And practical advice?
Yes, using appropriate, non-judgmental language. Signposting to support groups like the Herpes Viruses Association can be incredibly helpful. Discussing safer sex practices, consistent condom use reduces risk, though doesn't eliminate it. And the importance of disclosure to sexual partners, especially if a partner is pregnant, because of the risk to the baby.
Okay, so what is the long-term outlook, the prognosis?
The key message is that it's a chronic condition. There's no cure currently available that eradicates the latent virus. However, it is very effectively manageable for most people.
Does it get better over time?
For many people, yes. The frequency and severity of outbreaks tend to decrease over the years. The immune system gets better at controlling the virus. With antiviral therapy and lifestyle adjustments, people can live perfectly normal lives.
And prevention of spread. We touched on condoms and suppressive therapy.
Yes. Reducing the number of sexual partners lowers risk. Condoms should be used consistently. Critically, avoiding sex when active lesions, genital or oral, are present. Antiviral drugs, especially suppressive therapy, can significantly reduce transmission risk to a negative partner.
What about vaccines?
Research is ongoing, very active area. But so far, no vaccine has proven successful in preventing HSV infection or disease. Similarly, microbicides, gels, or creams applied vaginally haven't shown consistent benefit against herpes, though some might help reduce HIV transmission.
Okay. Finally then, let's touch on complications. What potential issues can arise from genital herpes?
Well, the most common complication is simply the recurrent outbreaks themselves and the associated physical discomfort and psychological distress or stigma we talked about.
Right. Any others?
Yes. Having genital herpes slightly increases the risk of acquiring or transmitting other STIs, including HIV. There are rare but serious complications in pregnancy transmission to the newborn during delivery, neonatal herpes, which can cause severe illness and possibly preterm delivery.
Neonatal herpes sounds serious.
It is very serious, although thankfully rare if managed properly during pregnancy and delivery. Other potential, though less common, complications can include things like autonomic neuropathy causing urinary retention, aseptic meningitis, inflammation around the brain, spread of the virus to other body areas through self-inoculation, and secondary bacterial or fungal infections of the sores, like candida or strep.
And specifically in immunocompromised people.
Yes, particularly in individuals with untreated HIV, primary or recurrent herpes can cause much more severe, extensive, and persistent mucocutaneous lesions. And we shouldn't underestimate the ongoing psychological and psychosexual impact that diagnosis can have on individuals and relationships.
Okay, quite a list, though some are rare. So to wrap up this deep dive on genital herpes, it's a common STI from HSV1 or HSV2, causing recurrent sores. Key points are asymptomatic transmission, the difference between primary and recurrent episodes, and effective management with antivirals and supportive care. No cure yet, but manageable.
Exactly. Understanding the virus, how it behaves, and the management options is crucial for anyone revising this topic. We really hope this breakdown has been helpful for you, the learner, and for anyone else listening. Remember, if you have more questions or other topics, do send them our way.
Definitely. And a final thought, perhaps. While there isn't a cure today, the research into vaccines, treatments, and even understanding latency is constantly evolving. Management and prevention strategies are improving all the time.
That's a great point to end on. Progress is being made.
And if you're revising for your medical exams, particularly the MSRA, make sure you check out pastmsra.com for loads of helpful resources.
And don't forget freemsra.com for fantastic free materials, too. Thanks for joining us for this deep dive.